Okay, friends. So we are now doing how to read an X-ray and some radiograph as example. So how to read an X-ray and some common radiograph. Plain radiograph are the most commonly ordered initial investigation by an orthopedic surgeon to understand the pathology, make diagnosis, or confirm clinical finding. The X-ray should be read in a systematic, meticulous manner in order not to miss finding and pick up even subtle change that will reveal some uncommon disorder. Also, consistency of reading helps communication with colleague. The listener should be able to visualize the finding as you are communicating. This essentiality has been nowadays lessened by picture or photo sharing app or messaging services on smartphone. What are the steps of X-ray reading? Place the radiograph in anatomical position first. Then description. Mention the anteroposterior AP view or view like AP lateral, followed by region observed, pelvis, cervical spine, thigh, etc. on radiograph, along with side if not axial, followed by age and gender of patient if known. Nowadays, digital radiographs contain all these information. Lastly, you should mention the date of examination, as follow-up radiograph would change for pathology. X-ray are read either from inside out or outside in approach. Commonly we follow the former approach. So here is a radiograph. The presented radiograph demonstrates anteroposterior AP view of pelvis with both hip in a 50-year-old male taken on April 15, 2014. The radiograph shows whole bony pelvis, upper part of femoral and lumbar 4th, 5th vertebra. So we will follow the former approach, being in habit of jumping to diagnosis, but the latter one is somewhat considered better. So soft tissue, note swelling, density of tissue and appearance of pathological sign like calcification, foreign body and presence of air in the tissue. Bones, note the outline density and contrast with soft tissue. As a whole, increased in fluorosis, reduced in osteoporosis. Periosteum, note the smoothness, periosteal reaction, newborn formation, lift of periosteum, thickness or bump, periostitis. Break or absence of it. Cortex, the cortex should be continuous and most thick in the diaphysis while thinning and virtually disappearing as a line in metaphysis. Note its continuity, especially break in it, its thickness, damage, lytic neoplasm, deformity, widening in Paget's, thinning in osteoporosis, and bowing in rickets. Finally, note if any implant is present and reason for it. Note the non-union or delayed union, change of union, malunion. Then endosteum, note as for periosteum, loss of it is seen in lytic neoplasm, haziness in osteomyelitis, disappearance due to bone forming neoplasm like osteoid osteoma. Medullary cavity, note the clear outline and differentiation from cortex. Corticomedullary differentiation is lost in osteoporosis, Paget's, and metabolic disease. Identify the pathological structure like lytic, sclerotic lesion, cyst, presence of sequestrum in osteomyelitis. Finally, make a note of intramedullary implant if present and reason for it. And at last, joint. Identify joint and note joint space. Degenerative change pathology like deformity due to abnormal growth, angular deformity, and periarticular pneumonia. Make a note of prosthetic replacement for the joint. Note the fitting, central placement, cementation, and articulation. Deformity, loosening, and sign of infection. How to read X-ray showing fracture. Radiograph showing fracture should incorporate the following: level of fracture. Divide the bone region into virtual third or halves and then dictate the site of fracture as upper, lower, middle third or junction of upper, middle third, etc. Displacement, mention translation, angulation, rotation, lengthening, shortening, overlap. Geometry of fracture line: transverse, oblique, spiral, butterfly fragment, wedge, comminuted, segmental, bone loss. Extension into joint: intra-articular fracture, impaction, comminution, condylar or volar dorsal displacement, displacement of fragment, and shift or tilt of joint. What are the prerequisites of taking X-ray? Two perpendicular view, oblique recommended for hand, foot, spine. Two joint, the radiograph of limb should incorporate joint above and below the target bone, especially in trauma series. Two limb, radiograph of contralateral limb is especially useful in children where fractures are often difficult to characterize. Two occasions, some pathology are better revealed after 2 to 3 weeks, like fracture of scaphoid. Nowadays, litigation and peer pressure does not mandate waiting for so long as investigation like computed tomography, CT scan can reveal it immediately. To injury, it is commonplace to find some group of injury together, so it is logical to order radiograph of expected other than injury simultaneously. So radiograph 1. Describe X-ray. This plain radiograph demonstrates AP and lateral projection of left forearm. Which one is AP and which one lateral is difficult as position of elbow and forearm is different and expected in trauma patient. Taken for a skeletally mature patient, radiograph should hold forearm with elbow joint and wrist joint and metacarpal of hand. Soft tissue shadow is unremarkable. There is displaced transverse fracture at the junction of distal and middle third of radius with dislocated ulnar head dorsally. The distal fragment is translated volarly with proximal migration and there is dorsal angulation at fracture. The wrist and elbow are unremarkable. What is your diagnosis? This is a typical Galeazzi fracture dislocation. Do you see something wrong in the radiograph and why? There is a band or tie at wrist. There is band or tie at the wrist, which should immediately removed as it may cause a strangulation effect producing compartment syndrome. What is the importance of this injury? The injury is classified as fracture of necessity and should be managed on emergency basis. Learn also other fracture of necessity and why are they called so. See fracture neck of femur for descriptive elsewhere in the book and read mechanism of injury and association of fracture from essential orthopedic principle and practice. Second edition, an answer for trauma. How will you proceed with the management? I will immediately stabilize the fracture so that secondary complications like soft tissue injury do not occur, and will counsel the patient and relative for the grievous nature of injury. I will plan for open reduction internal fixation ORIF of radius using AO principle and stabilize the distal radioulnar joint with K-wire in supination. So radiograph 2. Describe the X-ray. The radiograph shows AP and lateral projection of left elbow joint in a skeletally mature patient. The elbow joint region with distal arm and proximal forearm is demonstrated in this röntgenogram. The soft tissue shows some wasting of forearm and disrupted elbow joint clearly visible on AP projection. The forearm is translated laterally at elbow with loss of elbow joint articulation. There is an intra-articular bony fragment with some calcification speck near radial head, indicative of old injury on AP projection. Lateral projection demonstrates fracture of coronoid process of ulna and some anterior capsular calcification. What is your diagnosis? I will consider this dislocation of elbow keeping in mind the possibility of old unreduced injury that will be ascertained on history taking. Learn about classification of elbow joint dislocation and associated injury. What else you would keep in mind from this radiogram? This is an unstable injury, and if it is shown to be an old injury, then I will have to keep in mind the difficulty in reduction due to capsular calcification and possibility of myositis. How common is neglected elbow dislocation? Uncommon injury and rare to see in practice. Will you like to examine anything else clinically? Definitely I would like to examine the distal neurovascular status, as this could very well produce ulnar and radial nerve injury. I will also look for developing feature of reflex sympathetic dystrophy RST. How will you proceed? After proper history taking and clinical evaluation, I would like to get magnetic resonance imaging MRI of the patient to see status of ligament, myositis, status of articular cartilage and nerve entrapment in the joint. Ulnar nerve may get entrapped in the joint. I will discuss the option with family. What option will you discuss? Depending on preservation of joint, we can plan for open reduction of joint versus arthrodesis. Even after open reduction, there is a high possibility of remaining stiffness as there is capsular calcification with or without myositis. An additional need for ligament reconstruction does not always produce highly functional joint in such neglected cases that have to be immobilized for a significant duration in post-operative period. The patient will also need 2 to 3 months of physiotherapy, including multiple continuous passive motion sessions. Also, the joint may remain painful after relocation. Learn about the arthrodesis of elbow joint additionally. So radiograph 3. Describe the radiograph. The radiograph shows AP and lateral projection of left leg demonstrated while whole tibia and fibula with barely visible knee articulation in a skeletally mature patient. The soft tissue shadow demonstrates multiple irregularity, likely representative of puckered scar in the lower half and hypertrophy in the upper half of leg. The tibia bone overall demonstrates thickening well marked in the lower half with irregularity in cortex and irregular periosteal reaction. There is anterior and medial bowing of bone in lower half with well marginated lytic cortical lesion at lower and middle third junction, involving nearly one-third of the circumference of bone. The lesions are irregularly shaped, have a wide base and a sclerotic margin. Endosteum is hazy in the middle third with widening of medullary canal. There are multiple, 3 in number, poorly marginated lytic lesions in the medullary canal at proximal and middle third junction, without any definitive breach in cortex, but a small solid periosteal reaction anteriorly. Fibula also show anterior and medial bowing with hypertrophy in the middle third, prominent in lateral view. What is your diagnosis? I will give a differential diagnosis of multifocal osteomyelitis, operated case of osteomyelitis for distal lesion, while active proximal lesion, and operated case of fibrous dysplasia. Why do you call this operated case? The lower tibial lesion look like subserration done for opening the medullary canal and drainage of pus, as there is significant marginal sclerosis. Skin show scars. How will you proceed if this is chronic osteomyelitis? I will get sonogram done to look the culprit site of infection. Any other investigation would you do? I will get an MRI scan done with contrast to look for site of active disease. Though it is commonly an overdiagnosis in such cases, learn the classification and management aspect from elsewhere discussed in case of chronic osteomyelitis. And the final radiograph 4. Describe the radiograph. The radiograph show AP projection of pelvis with both hip in a skeletally mature male patient. Look at the pubic angle and genitalia, demonstrating whole of the pelvis, bony pelvis, with both hip joint and lower lumbar spine. The soft tissue shadow are unremarkable, but there is overall increased density of the visualized bone. Central line is broken at both femoral neck angle, and there is external rotation deformity of the distal fragment. There is clear break of cortices in the intracapsular femoral neck region, and trochanter are operated. There is varus angulation at the fracture. What is your diagnosis? My diagnosis is displaced femoral neck fracture of both femur with possibility of osteopetrosis or fluorosis. Learn about classification of fractured femoral neck. Kindly avoid the case discussed for non-union femoral neck fracture. Are you satisfied with the radiograph? No, I would like to obtain a lateral view. Why the fracture and displacement is obvious here. I would also like to look for posterior cortical comminution that has bearing on treatment and stability of osteosynthesis if planned. How common is bilateral femoral neck fracture and where do you see? It is quite uncommon but may be seen in pathological fracture, osteoporosis, osteomalacia, osteopetrosis, Paget's, ankylosing spondylitis, renal osteodystrophy, hypocalcemia, neoplasia, multiple myeloma, fibrous dysplasia, stress fracture of neck of femur are also commonly bilateral. High energy trauma, fall from height on both lower limb, standing straight, landing on heel. Will you order anything else if this is what you see in emergency department? Definitely after resuscitation and preliminary examination, I would like to get screening of a spine, lumbar, cervical and thoracic, radiograph of both feet. How will you proceed if this is the only injury? I will thoroughly evaluate for any metabolic cause of bilateral femoral neck fracture in this patient, as this may have bearing on treatment plan. As the patient is young, I will discuss with the patient and relative the pro and cons of hip preserving and sacrificing surgery thoroughly. I will be personally more tilted towards hip preservation. Radiograph 5. Describe the radiograph. This is a composite radiograph showing AP standing and lateral projection of both knee joint in a 74-year-old female, depicting also the lower part of femur, upper tibia and fibula. Soft tissue shadow are unremarkable. There is a degenerative change in both knee are more marked in right knee joint with valgus deformity at knee. Mild medial subluxation of femur, reduced lateral femoral tibial space with tibial osteophyte. Medial joint opening as visualized on AP view. On the lateral radiograph, there are prominent osteophyte formation, quite obvious in patellofemoral joint. What is your diagnosis? My radiological diagnosis is degenerative arthritis of right knee joint, grade 4 and grade 2 for left knee. Kell-Green-Lawrence radiographic grading. How do you say radiological diagnosis? Valgus deformity in primary degenerative arthritis of knee joint is uncommon and is more commonly seen in patients with inflammatory arthritis, so the diagnosis could change to rheumatoid arthritis clinically, so I mentioned only the radiological diagnosis. What will you do next? I will evaluate the patient for inflammatory arthritis or crystal arthropathy and also evaluate the patient for disability due to disorder, Western Ontario or similar scoring system, then plan treatment. What is the treatment for this case? If the patient is sufficiently disabled so as not being able to do routine work and her functions are primarily limited due to knee pain and arthritis, then I will suggest total knee joint arthroplasty. If patient is also emotionally stable and understand the limitation of this treatment, otherwise I will give a trial of conservative management with well advised physiotherapy and a strengthening exercise and functional rehabilitation of knee joint with adequate analgesia.